Yes, Siddharth.
So in all these years, our only vision was to become the most admired pharma company in the Indian pharma industry. Serving life, as our name suggests, will live up to our values and our name. And in the current time, we have taken initiatives to salute all the heroes who have made the ultimate sacrifice for the betterment of the healthcare of the people. And we pay our respects with a nominal 100 crore contribution to those who have made the supreme sacrifice for the nation. We are also pleased to announce the global patent of a novel anti-diabetic molecule GPR119, which will be valid up to the year 2037. So let's see together. Now I'll request Dr. Prashant to please take over the session and introduce the doctors, please.
Thank you, Siddharth. And as we are already aware, in this pandemic, few of the things which we definitely need to take care of our patient's sugar level and, of course, our patient's heart. And to talk about heart of our patients, I mean, amid this pandemic, we have our well-known cardiologist, Dr. Uday Jadhav, sir, with us. He's a consultant in cardiology and head CV Imaging Department, MGM, New Bombay Hospital. Dr. Jadhav sir is also honorary professor at MGM University of Health Sciences, and he's program director for ASH scientific meetings in India in 2013 and 18, and was program coordinator of ACC India Rhythm meeting 2014 to 19. He has been principal investigator of RAS India study and presented at AHA hypertension session on September 18 at Chicago. He is Vice President, Heart Failure Association of India and Joint Secretary, ISE, Honorary Secretary of CSI, Mumbai. Welcome, sir. Now, I welcome our next speaker, Dr. Ramachandran, sir, who is Director of Shri Shri Holistic Hospitals, Hyderabad, which is one of the India's largest individual case volume and expertise in cardiac ablations. He has done fellowship in pediatric electrophysiology from USA and fellowship in interventional cardiology, University of Alabama, USA. Welcome, sir. So I just wanted to ask, before we go into the exact session, can we have introductory remarks from Dr. Uday Jadhav, sir, and Dr. V.S. Ramachandran, sir, both? So, sir, what do you think about cardiac care in COVID time? Dr. Uday Jadhav, sir.
Yeah, so thank you very much. It's nice to have Dr. Ramchandra with us today. Welcome, sir. Yes, Dr. Prashant. As we look at COVID care over the year and a half, most of the acute problems that we have been facing or aware of starts with 3 or 4 primary areas, starting from the presentations of acute coronary syndromes, right? So you have STEMI, you have non-STEMI patients who come in. And we have 2 aspects to deal with: patients who have a cardiac problem, pre-existing, and now present with acute event, whether that may be acute coronary syndrome or acute heart failure. And they have pre-existent coronary artery disease or heart failure and have, for some reasons, now come up with acute event. So that's one challenge. The other challenge, and I'm sure Dr. Ramchandra will explain us very nicely, is our patients who have a COVID-19, SARS-CoV-19 infection and have presented with acute cardiac problem. So I think we must put this in perspective, that there may be a little difference in the way we deal with them. Some subtlety will deal with them, but it's a very complex matter because COVID care has deviated from a personalized care to more a system-related approach as to how we can improve it. So that's one comment. Second comment, and that's my interest largely, of course, what do we see on echocardiography's imaging, and how do we utilize this aspect in clinical care? Again, what are the limitations of imaging in the acute COVID settings, and how do we deal with it in a practical way? The third issue, and Dr. Ramachandran has been an electrophysiologist, he will explain us some of the cardiac arrhythmias that come up, both tachyarrhythmias, bradyarrhythmias in the acute phase. How do we deal with it over a period of time? And lastly, and the fourth, and I think the very vital thing, is, according to me, the way, having been involved in COVID care also actively, the legacy effect, unfortunately, that may linger for a while or may come up for a while in terms of the burden of heart failure that we will lead, that may come up in India. Will we be seeing more cardiomyopathies? Will we be seeing more heart failure as a lingering complication of COVID? And already there is a reasonable data that comes up, and every day we have started learning new things as the initial phase of COVID has ebbed, both the first wave and second wave. And then how do we deal with it? What's our experience in pharmacotherapy? How are drugs going to be repositioned? Are the commonly used cardiovascular drugs, the ACE inhibitor, the ARBs, statin therapy, for example, very vital, the antiplatelets, the anticoagulants, and the heart failure gambit of SGLT2 inhibitors or ARNI therapy, will they make an impact on these patients? Will it be reversible? How will the CMR differentiate these two sets? So very interesting aspects. And thank you, Dr. Prashant. We'll take it forward with Dr. Ramachandran.
Thank you, sir. Dr. Ramachandran, sir. Sir, your opening remarks, and then, sir, definitely we would like to hear from you first your presentation, sir. Your part.
Yeah, thank you, Dr. Uday and Dr. Prashant. So, as you know, COVID has been a very bad disease for us, especially in the second wave. But very peculiarly, the first COVID patient that we saw was a case of myocardial infarction. This man was traveling in a car and he had arrested in the car. And so they resuscitated him in another hospital and intubated him and sent him to our place. And so before they sent him here itself, they had a CT scan of his chest done. And that showed Corad's 5, and it wasn't very severe, but definitely he had unequivocal COVID. So we had two options because this man had arrested and he was throwing very frequent ventricular tachycardias. Usually we would just lyse them because of the huge clot burden that we expect in these patients, but we went ahead and did a primary angioplasty, and he recovered amazingly well with no other complication. And I think around a month or so back, he did not vaccinate himself. So he again got an infection even in the second wave. And this time it was very light. Of course, we told him not to stop any medications, not to change any medications. Most importantly, he was on some ACE inhibitors, antiplatelets, statins. He just continued them through the disease. And of course, he didn't have any problems this time. So right now, he actually called me today and was asking when he should get vaccinated. I think this time he's a bit more careful. So I told him, according to WHO, maybe he can wait some time and maybe he can get an antibody test done to help us decide when we should get him vaccinated. So that is the scenario. And very peculiarly over the last, I think 15 days, we have had some 6-7 patients post-COVID who presented with myocardial infarctions. They came in a bout. Like most of us know, for doctors, we know patients seem to come in a bout. So they came in a bout, and all of these were young people who hardly had any symptoms. And very peculiarly, 4 of them had their D-dimers and all done within 2 to 3 days. And most of them were clustered around 15 days after the recovery from COVID. And all of them did well. Some of them, we lysed them intracoronary, some we put stents, and some, of course, IV lysis. All of them did well and went home without much damage. But like Dr. Uday said, this is a serious issue, not only the myocardial infarctions, but what COVID can do to the myocardium itself is also a serious issue. So we'll go ahead with the presentation
Yes, sir. Sorry.
Yeah. Can you hear? So it's okay. Yeah. So we'll go ahead with the presentation that
Sure.
Mankind gave us. So this is the presentation on bisoprolol.
No, sir, no, not visible.
Yeah, I think I have to share the. So can you hear me?
Yes, sir. Yes, sir. You're audible.
Okay. So I think there's some.
Sir, if there are no changes in the presentation, I can share from my end, sir. Dr. Ramchandran, so your video has paused.
During.
Yeah. Hi, sir. Actually, your video was paused for some time. So, if there are no changes in the presentation, can I share with from my screen, if that is okay with you, sir?
Yeah, see this? I think now you
Yes,
can.
yes, yes. It is coming.
Yeah. Okay.
Yeah, it is.
So yeah, so like I said, one is an acute presentation and one is a presentation with myocardial infarction during any phase. Like we said, during the active phase or during the recovery phase. And this seems to happen up to 1 month. After 1 month, really the number of cases that people have seen is less. And so that is about the myocardial infarctions. So it definitely seems to be more common in patients who already have some cardiovascular disease. But like I told you, all these patients that have come recently to us were young patients, never had any cardiovascular disease. And the very peculiar thing is during recovery, their inflammatory markers and all could be normal. Like out of these 6 patients, I think the majority of them had normal CRPs, normal D-dimers, before they presented. And of course, after they developed the clot, the D-dimers got elevated. So which basically tells us that it doesn't need to be a very systemically pro-inflammatory condition. It can involve the coronaries somewhat selectively. The other thing is, of course, like Dr. Uday said, is the myocarditis element. And this we commonly see as bradycardia during COVID presentation and later on tachycardia, which is a very common thing. By now, most of our doctors must have noticed this as the recover. Actually, our chief pulmonologist always used to say that if the heart rates were getting up, he used to feel happy because he would know that his patients were going to recover. So that was how frequent the tachycardia was. During recovery, they become tachycardic, many of them. Why they have it, whether it is some autonomic imbalance or whether it is a myocarditis, we are not sure. We know of a very large study done in Germany. At that point of time, this was in the first wave. They said almost 70% of people had some amount of myocarditis on MRI, even after 2 to 3 months. But this was not at all the situation when in the study done at Jayadeva Institute in Bangalore, where they found very few people having myocarditis during recovery. So whatever might be the cause of tachycardia, the myocarditis as a cause of tachycardia is something that we cannot ignore. So that is one thing. So mainly the heart attacks and the myocarditis parts. And then, of course, the sudden cardiac death part. We don't know why some people die suddenly, especially when they are exercising post-COVID. This is something that we have seen commonly, that people who exercise post-COVID, despite having normal oxygen saturations. So we are not talking about people whose oxygen saturations are coming down when they exercise. We are not talking about these people who desaturate when they go to the toilet and they fall down in the toilet. We are not talking about these people. We are talking about people who seem to be recovering well, who do not have their saturations dropping while they are exerting, but still some of them have cardiac events, and definitely much more frequently. The fourth thing is, of course, not related to COVID. It's something related to vaccines. Recently, there was a study that showed that post-vaccination, especially after the mRNA vaccines, the younger people seem to be having myocarditis at a rate which is 2 to 3 times what you would expect in that population. So that is something of a concern again, because you are vaccinating a huge number, but luckily the number of people who did this were very few.
Sir, sorry to interrupt you. Sir, are you changing slides? Because we can see only bisoprolol and the
No,
heading
I'm not
slide only.
changing slides. I'm
Oh,
just
okay.
giving the introduction. So
Okay.
this slide thing, I'll go quickly. So understanding bisoprolol, like it is a sympathomimetic membrane with membrane stabilizing actions. It has a very high degree of beta-1 selectivity. So it is more beta-1 selective than metoprolol or etinolol. So it is used in heart failure, hypertension, MI, and arrhythmias. So basically across the whole spectrum of beta blocker usage, this highly selective beta blocker can be used. What are the actions and the important benefits? Long duration of action. So it's basically a once-a-day drug. Significantly reduces exercise tachycardia, reduces systolic and diastolic blood pressures, significantly decreases vital capacity and forced expiratory volume, significantly reduces peak expiratory flow rate in asthmatic patients as you would expect, and reduces myocardial oxygen demand by up to 34%. This we know that beta blockers do by decreasing the heart rate and decreasing the inotropy of the heart. Beta blockers indications and benefit, mainly they are used across 4 spectrums. The most important one, and that which is going to stay the longest probably, are heart failure and arrhythmic actions. So manage arrhythmic conditions, which are very important. This is one reason why your post-MI patients get beta blockers. It is not to improve their LV function, but to basically decrease arrhythmic deaths. Suppress ventricular ectopic beats and arrhythmias, prevent sudden cardiac death in a variety of heart disease, and control ventricular rate in order to evade ventricular activation during atrial fibrillation. So these are the main actions as far as the electric properties of the heart are concerned. So it has, it behaves negatively inotropic during the acute phase, but on the long run, especially in patients with heart failure, it is the most positive inotropic agent that we know of, whether it is increase in the ejection fraction or the decrease in mortality. Exercise capacity is not significantly reduced in people who are treated with highly selective beta blockers, although this is a common problem with non-selective beta blockers. The decrease in VO2 max is also very little, and in fact, there are some small studies that show that there could be an increase in VO2 max if you use beta blockers in some patients who have pro-inflammatory conditions. How about the skeletal muscle blood supply? We know that people who have peripheral vascular disease, beta blockers can aggravate claudication, but at the same time, they have found that in patients who have coronary artery disease, actually claudication may not get worse when you use beta blockers. And this could be something to do with mitochondrial adaptation at that level also. So beta blockers are very controversial drugs. And the greatest controversy and the biggest benefit has been its positive inotropic effect. See, when they started beta blockers in heart failure, it was quite counterintuitive. So where do you use this? You would not use them in patients with AV block, bradycardia, or asthma. Say in a patient with a first degree AV block with say a prolonged PR interval, you can still use it with proper monitoring. And you would definitely use it in all patients with heart failure. There's hardly any patient where you would not use it. As you know, the 4 drugs that are mainly useful in heart failure, number 1 drug is of course beta blocker. The second most important drug are the SGLT2 inhibitors. The third are the ASR, ARBs, or ARNI. And the fourth, of course, are the mineralocorticoids. How does bisoprolol score over the other beta blockers? As you know, it's very well tolerated. People who have used this drug, in my own experience, bisoprolol and nebivolol are very well tolerated beta blockers. A very high oral bioavailability. It's cleared in equal proportions in hepatic and hepatically and renally, so that you can use this drug quite safely in both these situations. It has a long elimination half-life, has unique pharmacokinetic properties. The metabolic disturbances, including involving blood sugar, insulin sensitivity, and the lipids, are mild compared to the other beta blockers. Reduces mortality in patients with chronic heart failure, regardless of etiology or severity. So it seems to have some advantages over the other beta blockers. So it possesses both lipophilic and hydrophilic properties, and that's why it's equally excreted by the kidneys and by the liver also. The peak plasma concentrations are reached within 3 hours of a single 10 mg dose. The plasma concentrations are quite stable, maintained around half of the peak. They're rapidly and widely distributed, hardly any placental transfer, and a small degree of penetration into the blood-brain barrier. Binds to human proteins to the extent of about 30%. So it is not a very highly protein-bound beta blocker. Less than 10% of the drug undergoes first-pass metabolism, which means you don't need to depend on a first-pass metabolism for this drug to be active. The elimination half-life is 9 to 12 hours in healthy subjects and can increase in those with renal failure or in patients with severe heart failure also. Now, if you look at these beta blockers that we have, you can see atenolol, bisoprolol, and metoprolol are the cardioselective ones, out of which the most cardioselective one is, of course, bisoprolol. So if you are looking at cardioselectivity as something that gives you advantage, bisoprolol is the drug that you need to look into. And the other very favorable thing is it has equal renal and hepatic excretion also. Carvedilol is something that we use in heart failure quite commonly because of the studies that it has. But it is a non-selective drug. Of course, you all know that it has some antioxidant properties and it may have some vasodilatory actions also. Nebivolol, which is not given in this chart, also has nitrous oxide releasing properties in addition to the other ones. So basically 4 drugs are approved for heart failure management. These are metoprolol, bisoprolol, carvedilol, and nebivolol in one study that involved old patients, elderly patients who had COPD. So here, these people seem to do well on nebivolol. So if you want to see which are the patients that, which are the drugs that you can use in patients with some amount of electrical problems as well as respiratory problems, the ones that are most friendly to us are bisoprolol and nebivolol, not carvedilol or metoprolol. And of course, propranolol is a non-selective one, and many doctors especially use propranolol because it is non-selective. Patients who have a lot of sympathetic drive, who have anxiety, palpitations, some people would like to use propranolol because of its sort of smothering action on the brain also. So if you look at the superiority of bisoprolol over other beta blockers, angina, all beta blockers are considered to be effective. All the people prefer bisoprolol or metoprolol. Especially, people, like I said, those who have peripheral disease, the drugs that you usually would use are bisoprolol or nebivolol. People with arrhythmias, again, you would use metoprolol or bisoprolol, primarily because the studies mainly involve these drugs. And the water-soluble beta blockers like atenolol and other beta blockers are used less because of their CNS side effects also. Heart failure, like I said, 4 drugs are approved, out of which these are the 3 main drugs, and of course, nebivolol can be used. And the good thing about bisoprolol is it's in heart failure, these people are on a lot of other drugs, and bisoprolol is the one that has the least interaction with other medicines, if you look at the other beta blockers. Hypertension, all beta blockers are considered to be equally effective. And like I said, bisoprolol may be preferred if you don't want a drug that crosses the brain, blood-brain barrier, or in those with peripheral vascular disease or those with lung problems. This is primarily because bisoprolol is the most selective beta blocker that we have in clinical use. Post myocardial infarctions, most of us would use metoprolol or bisoprolol. Again, because of its highly selective action, And of course, there are some cardiologists who would use drugs with more membrane stabilizing action. And here too, bisoprolol does well compared to the other beta blockers. So we are looking at COVID. Like I said, the main things are the myocardial infarctions, the myocarditis, and the sudden cardiac deaths. These are the main things, apart from the troublesome causes that are bradycardia in some patients and tachycardia in those who recover. And of course, blood clotting in general is something that can be dangerous as far as pulmonary embolism or peripheral clots also, or brain strokes are concerned. But as far as the heart itself is concerned, these are the main three things that we are worried about. So this is a slide that shows that beta blockers are underutilized in COPD, and that's true both in COPD and peripheral vascular disease. Beta blockers are underutilized because many people feel that their asthma will get worse. This might be true with non-selective, but in the highly selective beta blockers like bisoprolol, one can definitely give a small course of the drug and see if the patient worsens, and most patients do not worsen when you use these highly selective beta blockers. The potential non-cardiac targets for beta blockers in COPD, like I said, wherever there is a marked pro-inflammatory condition, whether it leads to inhibition of endothelin 1 or reduction in the circulating pro-inflammatory cytokines, inhibition of neutrophil chemotaxis and respiratory burst, and reduction in the globular cell number and mucus release. Now, these are things which most of us do not know, that beta blockers do have a soothing action on all these inflammatory markers in the body. So beta blockers not only suppress the renin, angiotensin, aldosterone system through both action directly on the juxtaglomerular apparatus, as well as they suppress the sympathetic axis, but they have this anti-inflammatory actions also, primarily by their action on the sympathetic nervous system. So if you look at the beta blockers and effects on the pulmonary function, you would be surprised to see that there are some studies that show no deleterious effects on the FEV1 or the FVC. This is because when you use highly selective beta blockers, you may not have a problem unless you go to very high doses. So this is also something you can use doses, say bisoprolol 5 mg would almost never cause a serious increase in the respiratory problems, unless of course it does happen in some people, but in most people you can and you should try beta blockers if they are indicated. So there have been some studies that showed this, like in the previous slide only, that there has been no worsening of the FEV1 response after you use beta 2 agonists also. So comparing, if you look at COPD also, the same thing, the choice of beta blockers and effects on the pulmonary function. Comparing 24 COPD patients on beta blockers to patients not taking beta blockers, there's been no difference in exercise capacity or gas exchange, despite lower heart rate and blood pressure. So basically, just to summarize, you don't need to be afraid of using beta blockers if you use highly selective beta blockers in patients with either COPD or peripheral vascular disease, provided you can start them and maintain them at a median dose and look for worsening of these symptoms. Most of them will not worsen, and therefore do not hesitate to use beta blockers where they are solidly indicated in many of your patients. So what about COVID-like illnesses? This is in COPD, like we have already looked into this, where and this is a trial that showed that FE1 actually significantly improved with bisoprolol. So how does it do it? Probably it does it like we already talked about, its soothing action on the inflammatory condition of the lungs. So the most important thing is, of course, the action of beta blockers in reducing the heart rate, in preventing decrease in myocardial dysfunction, and of course in people with the long QT syndrome. As we know, like people with long QT syndrome, the mainstay of treatment is beta blockers, and you can use this wherever long QT happens, whether it is even because of drugs. The same benefit seems to happen when you use beta blockers, which means not only in a genetic form, but wherever you get long QT for some other reason also, beta blockers seem to be doing as well as in the long QTs. And there's other postulation also that beta blockers can block the entry of SARS by lowering the ACE2 levels. As you know, the main receptor for the COVID is the ACE2 receptor. Whether it is in the respiratory epithelium or in the vasculature, the ACE2 receptor is the main receptor for the COVID spike protein. And by decreasing the ACE2 levels by beta blockers, maybe you can decrease the SARS entry into your body. So this is a figure that shows you how it might do it. So it might do it by decreasing the activation of the renin-angiotensin system. It can do that directly by its action on the juxtaglomerular apparatus, or it can do that by decreasing the sympathetic drive. So whichever way it does it, if it decreases the number of ACE2 receptors, then it can have a good salutary action on the primary infection itself, and later on also in reducing the complications of COVID like ARDS, septic shock, and respiratory failure. So like I said, the main thing is about the QT. There are a lot of drugs that we use, especially the macrolide antibiotics, the antihistaminics. Like even we know that antihistaminics, like the most commonly used ones that are used now, many of them can cause QT prolongation. So when you use, say, something like azithromycin, along with cetirizine, along with, say, some other drugs, and the person could be having hypokalemia or some other triggering factors also. This can lead to long QT and could probably explain the sudden deaths that we see in COVID, and in which case, if there is an indication for adding beta blockers, definitely we should add these highly selective beta blockers. And of course, there's a large segment of people who come to you with high heart rates. Here also, you can add these drugs to both give them the safety of the prevention of long QT related complications, as well as symptomatic relief. So in clinical practice, how do you use them? Like I said, you start with a lower dose and increase them. And you can increase them fairly rapidly in cases of hypertension, as well as for its antiarrhythmic effects. In heart failure, of course, the patient needs to be euvolemic before you increase the doses of beta blockers to the optimal range. So the take-home points is in COVID, whether the patient has tachycardia, sinus tachycardia, or some other indication for beta blockers, use of highly selective beta blockers in these patients could prevent the inadvertent complications that could arise due to QT prolongation in these patients. And of course, it is much easier to use these highly selective drugs like bisoprolol rather than many other drugs that may increase respiratory or peripheral vascular complications. Thank you.
Thank you so much, sir. Now with this, we move forward to our second session of this evening with Dr. Uday Jadhav, sir. Sir, over to you.
Thank you. Once you stop sharing the screen, then I'll start the screen.
Huh. Yes.
Thank you. Dr. Ramchandran. That was very nice, very elaborate discussion on how we use beta blockers. So let me start with my presentation, and maybe I'll make some offhand comments on this, so that will become quicker then. Dr. Prashant, the screen and audio is good?
Yes, sir.
All right, thank you very much. And so I'll give you an update on what's going on with statins in COVID-19 and the potential role of statins. Okay. Now, this is something which has been talked about innumerable times. And I'm going to put statins where it can be located on this aspect. So there are two very fundamental things about COVID. One is the entry of the virus into the cell, and on the cell wall, the replication. What the virus causes is a downregulation of the ACE2 expression on the cell receptors, right? So if you have a therapy that can upregulate the expression of on the cell receptor of the ACE2, then the virus has a lesser chance of entry. So first is the entry point. And this is where statins is going to play a role, and we'll talk about it. Secondly, the viral replication. Is there some way in which the virus replication can be prevented by statins by having an effect on the cell level? And third, what happens in terms of the virus then getting into the cell, getting engulfed into the cell, or what we call as endocytosis and replication further? Can statin have a role there? This slide, in my opinion, is the most important slide. So what actually happens is that there are lipid rafts. What are lipid rafts? These are packets of vesicles on the cell surface. These are packets of vesicles on the cell surface. And these lipid rafts are able to concentrate the viral replicating factors. So if you can reduce the concentration of the cholesterol in the lipid rafts, the viral replication can be potentially inhibited. We do not know it can be prohibited. It's too large a theory to put across, but inhibition for sure and certain. Once that happens, statins, by its fundamental property of reducing cholesterol in the lipid raft, will prevent the assembly of the receptor and the viral replication. Thus, the virus ability to adhere to the host cell will be reduced. I think this is extremely important. Statins destabilize viral replication. So very important, so very important. And then what it does further is, it has various mechanisms by which it can play its anti-inflammatory role. So it can downregulate the NF pathway. It can decrease the inflammasomes. It works on the inflammasomes, particularly the NLRP3. Remember the days of Jupiter, in which a study when rosuvastatin was used to decrease the CRP, decrease interleukin-6, and decrease the LDL cholesterol. And it was found at that time that the NLRP3 inflammasome activation also can be downregulated. In fact, Paul Ridker went further ahead and went into the theory of using an anti-inflammatory drug, particularly to reduce the LDL cholesterol within the cell membranes. He used a drug called as canakinumab, which never saw the light of the day, but there has been further research on that. And that brings me to another important and nice little information. I know some of you, I don't use it much, but some of you use colchicine for treating COVID-19. It's potentially a drug that will also have an effect on downregulating the inflammasome activation. Now, COVID doesn't use just one inflammasome. There is a, what do we say? There is a panel of inflammasomes it uses. Some of them could be benefited, other may not. And therefore, colchicine, though a great drug, may not be able to by itself knock out the complete inflammasome mechanism, right? So let's keep this in mind. Also, if you get a COVID-19 and scared, then we already know, I mean, this is the STEMI data which everyone shares, that you decrease by its prothrombotic profile the entire inflammation. Not just that, all the pro-inflammatory cytokines. Given this backup, and I'm going to touch base on this at the end, do we have clinical studies? Do we have a data? So first came the Chinese study in which they looked at close to 14,000 patients, right, of which 1,200 did receive statins. And they found at the end of 28 days, a 42% reduction, relative risk reduction in terms of all-cause mortality. And that was believed to be the effect. When they looked at the death rate in matched statin users and matched statin non-users, the difference is truly very significant. 5.2% in matched statin users, 9.4% in statin non-users. Now, this was statistically significant, going down to more than 40%, even if we may say this is not a multivariate analysis. This is not a data which always takes the confounders in mind, but still it's an important hint. We need to look at it very carefully. Then came the meta-analysis in American Journal of Cardiology. That started the whole renewed interest in statins in COVID-19. So they looked at a pooled analysis. And when they put the pooled analysis together, there was a 30% relative risk reduction in a hazard of severe disease. So that's vital, that's important. This particular article from San Diego by Laurie Daniels came up to, if patients are on statin and they get admitted with COVID-19, what actually happens to them? This article, I think, is important at that point of time because it dwelt on the background history of statins as an anti-cholesterol drug, but also importantly, the pleiotropic effect, right? We know it has antioxidant effect, it has anti-inflammatory effect, anticoagulant, and antithrombotic. Now, all those components are vital in terms of what it does. So it started looking at what happens for all these three drugs from progression to severe disease to recovery. It was retrospective. Looked at 170 hospitalized patients, and they also looked at all the other drugs. One of the important aspects that came out was that diabetes was independently associated with increased risk of severe COVID-19. I'm not talking of mortality. I'm talking of who are the patients who in the first place get into the hospitals, and if they are diabetics, will they get into a increased morbidity and increased mortality? And as you can see, diabetes was right up the chart there. And ACE inhibitors were good, so it was safe. Statins increased the rate of recovery. And I'll show you a different data after this from the agency data that came up. The median time to recovery was 7 days, and it was shorter in patients who were given statins than otherwise. The recovery was better, right? Severe disease was less. One of the WHO parameters of recovery is how many days it takes in the hospital to recover. That led to this biological plausibility that there is this anti-inflammatory role. This is an immunomodulating role. And that's how the inhibition of the coronavirus can get affected through primary pro-inflammatory response activity of statins, right? So after this study, we go back again, and I'm again saying this, we must go back to Paul Ridker data. He showed on high CRP how rosuvastatin had a reduction of major effects. And remember, it was not just Paul Ridker's work on LDL reduction. Is the Journal of Invasive Cardiology then published the work on the reduction of IL-6 and the PAI, both genetic expression of the inflammatory marker. So statins fundamentally are very strong. These days we look at interleukin 6. Has it shown result in several infections? Of course, yes. Avian influenza, H1N1, and the Ebola In fact, it's interesting to look at it. Ebola actually it worked. But then this clinical study was given up later. It never saw the light of the day as a prospective further trial. Ebola went down, so the study went down. But then there was a reasonably good data that came up of how it worked on inflammation. I am saying the same, putting the same slides again for your understanding. Now that the virus, statin works on the entry of the virus, it also may work in terms of the inflammation. Is that important? Yes, because we now start looking at the acute respiratory injury, cytokine storm, we are worried about it, the vascular collapse, where there is a microthrombosis all over. And mind you, statin works very well in microthrombosis. In fact, rosuvastatin did show a salutary effect on reduction of pulmonary embolism in those patients who were given early in the Paul Ridker study. So multiple ways, 3 ways. If you go down the slide, inflammatory cascade, so inflammation. So you'll have lesser plaque rupture, you have lesser shear stress on the vessels. Hypercoagulable state of COVID, so lesser arterial and venous thrombosis. And the cardiovascular complications that COVID patients work with or go and get into is what will happen by statin as a therapeutic agent. Let's see more trials that came up later and were reported. HARP2 was a trial that looked at simvastatin in ARDS before, and they showed the same data that there is a reduced mortality in the hospital. A number of trials were put together for the potential beneficial role of statins, and I'm saying this again. Here you go. 36% lowered mortality in COVID-19. They just published by the Arteriosclerotic Journal. 36% significant lower mortality in COVID-19, particularly in patients who are on statins. That encourages you not just as a therapy for COVID, which is one of the proposition, but that we need to increase the use of statins in patients in India at a very low threshold of LDL cholesterol, thinking that we can get into potentials not just of COVID, but in coronary artery disease and together, both the aspects, right? A very new paper just communicated by Nature is looking at the antecedent statin use and decreased mortality. Now, this is a new paper, again, telling you different from the AJC paper, but almost on similar lines. Exactly from 46%, here is a lower inpatient mortality reduction by 53% in patients who had a statin use. CRP went down, IL-6 went down, lymphocytes improved, neutrophils went down. And if you look at statins versus not statins for CRP, wherever those blue lines are is the drop in CRP over a period of time. If you simply put it as statins, those who made it and those who did not made it, those who are statin survivors and those who are not on statin survivors, you can look at the CRP levels so much better for patients who were on statins. So it did drop the mortality. A propensity score match analysis, where you looked at more 2,000 patients or more, small but significant decrease again in mortality. That statin, what does all this also put it? You can take it the other way from the meta-analysis. At least you know that COVID-19 related mortality will never be harmed by statin. It looks like it has a mitigating effect or a toning down effect on the severity of what COVID would do. A new registry just published a couple of months back is the semi-COVID-19 registry. It comes from Spain, and they went through the second and third wave almost. They analyzed 2,900 patients, and what did they find? I already said on cardiovascular morbidity, we talked about all-cause mortality, 33% reduction. So I'm just looking at the data. Everything is crossing the figure of 30%, between 30 and 50% is the benefits on all-cause mortality. AKI went down by 24%. Acute lung injury went down by 22%. Sepsis went down by 50%. Mechanical ventilation went down by 30%. I think this is a very, very good data from SEMI. There is also Inspiration S trial. It's a 2-into-2 factorial design in patients who are on ICU. Now, I know there is a good data on rosuvastatin. I was waiting for a data on atorvastatin, and this is one of the data on atorvastatin. And what did it try to do? Of all the patients, after the sample size were analyzed and the patients were put on the clinical trial, not a big trial, but still a good clinical trial, they looked at the composite of VTE, arterial thrombus, ECMO, and all-cause mortality, basically trying to look at also the anticoagulant effect of the drug. And you can see everywhere a 16% reduction in mortality and the composite endpoints, and venous thromboembolism went down by 29%. I don't think ventilator-free days would come into picture then. The primary efficacy outcome, mortality, VT, all-cause mortality, ischemic stroke went down by 16%, but not statistically significant. Still gives you the signals of safety. What is the other thing? The symptom onset, the benefits where statins were better. When the symptom onset is less than 7 days, that's the green chart. So this is a hypothesis generating thing. Do we start statin in the early infection phase where there is already a lymphocytopenia, because that's one of the markers? You will have an effect on the lipid drafts. Once the lipid drafts are affected and the cholesterol content of those vesicles go down, the virus is not going to proliferate. Once the virus gets into the endocytosis phase, the endocytosis for multiple reasons will be inhibited. And thirdly, because it has an effect on infamosomes, the later path of replication and getting into a cytokine storm will get better. It works in ICU patients. A lot of clinical trials are already on that. We know that we have a higher incidence of COVID-19 and CAD and mortality, so I think it should really work very well. So this is the rationale of statin use in COVID-19. Now, let me tell you another thing, which is besides these slides, it's nothing to do with slides, that, the cell membranes have lipid and protein-rich domains. These are called as sphingolipids. So what are sphingolipids? They are the they are the membrane regulators of viscosity of the cells. We know that in COVID-19, the severe cases have pulmonary leakage, right? And the pulmonary leakage is connected with the lung injury. Sphingolipids are essential in keeping the integrity of the cell membrane by maintaining its viscosity. If you use something like a sphingolipid, then it will protect the patient from coagulant and microthrombosis and lung injury and prevent the pulmonary leak of acute lung injury. Long back, if I correctly remember, 4 years back, there was a drug called fingolimod. It was called as a sphingomymetic drug. It was used in SARS. And fingolimod showed a decrease in IL-6 and the entire cytokine inflammatory markers and inflammasomes. Statins, therefore, fingolimod was not a sphingomymetic drug. Statins, therefore, will become a sphingomodulating compound, and therefore it will have an anti-thrombotic, anticoagulant role, and that's how it will protect these patients from getting into a bad lung injury. So, as a conclusion, statins may be used in the community at large, who are indicated keeping a low threshold for LDL cholesterol to protect cardiovascular diseases. They should be used early, in early COVID. If patients are on statin, mind you, do continue them. I thought we had only data on rosuvastatin when I talked about this. When AJC journal published it, I think I was among the first to speak about it. And then I'm seeing the literature build up over the last 6, 7, 8 months, and now studies with atorvastatin. So as a class effect also, it looks very, very good to me. Very robust use of this drug. Thank you very much, Dr. Prashant, and you can take it forward, please.
Thank you, sir. And may I request Dr. Ramachandra sir also, please start your camera, sir. So first of all, I must say thank you, Dr. Dajada sir and Dr. Ramachandran sir, for this wonderful session for the cardiac care in COVID-19. So, sir, with your permission, I know, sir, the time is over, but sir, with your permission, can we take few questions?
Yes, yes.
Sir, the first question they want to understand about, like patients suffering from diabetes, hyperlipidemia, angioplasty. So, what are the precautions and medications they need to take care?
For diabetes, hypertension, and
Dyslipidemia,
what?
hyperlipidemia, angioplasty
Okay.
done
So the
for
entire
that patient.
metabolic.
Patient is already diabetes patient, sir.
Just quick comment. Be aggressive about the diabetes. Make sure that sugars are going to get low, for the simple reason that steroid has become the standard of care. So you expect a heightened blood sugar at that point of time once they get into the COVID times. And also that we know now COVID will have an effect on beta cell secretion and insulin resistance both. So we see more hyperglycemia and de novo onset of diabetes. So aggressive control of sugar. The best drugs to use as of now are insulins, insulin glargines, regular insulins, and probably as a neutrality DPP-4 inhibitors. SGLT2 inhibitors, there's nothing add-on after the DARE heart failure study, so probably they don't make a great difference to COVID. Hypertension, ACE and ARB are safe. So that message has been circulated for a year now. We stick to it, keep the blood pressure normal and less, make sure that they probably are not on too much diuretics, avoid hypovolemia, avoid acute kidney injury during the COVID times. Statins, just go ahead and continue them. There's absolutely no problem. So those are my three simple messages.
Thank you, sir. I guess I will take next question, Dr. Ramachandra, sir. Sir, the patient in raised level of D dimer in COVID-19 patients, how to include in low molecular weight heparin should be given. So, what is the dosing schedule and what are the precautions we need to take care, and when to switch over to oral anticoagulants, sir, and for how long?
See, there is a huge controversy about the use of anticoagulants in the recovery period. But as of now, during the acute phase, I think there is reasonable means standardization of the treatment schedule in that most patients get a moderate dose of anticoagulation, which means around 40 to 60 milligrams of enoxaparin once a day. And if the D-dimer is high, they go into a dose which we usually use for ACS, which is 1 milligram per kg twice a day. And most sort of people who have done not really a meta-analysis, but looked at all the trials, they conclude that maybe enoxaparin is the best thing to use. Because with heparin, there is a problem in some of these people. They seem to develop some sort of lupus anticoagulant-like thing, which means that you cannot use APTTs properly to guide your treatment. So in which case, it might be better to depend on a low molecular weight heparin. How about using DOACs right from the beginning, oral tablets, instead of using enoxaparin, which is hard to get nowadays? Of course, it's improved, the availability. There are not many trials using DOACs right from the beginning. So most people would just stick to using them, using moderate intensity of enoxaparin during the infection. And if the person has very high D dimers, or the person's saturations are dropping suddenly and you are suspecting microthrombi, or you have clinically evident thrombus, then of course you will use a high dose, the dose that we use for ACS, which is twice a day, 1 milligram per kg. And during the recovery phase, also there's this controversy of how long to use and what to use. If whether the D dimer is high or not, most people in India would use aspirin or an antiplatelet agent for 1 to 3 months. This is something that Indian doctors are sort of doing by themselves, because there are really no guidelines to say that this should be done. And as far as aspirin is concerned, really I was amazed at Dr. Uday's knowledge of COVID and statins and all. For me, This was amazing, the presentation. So aspirin, as you know, there is a trial in Israel, a pretty large trial, which said that if people are taking aspirin right from the beginning, their chances of becoming infected with COVID itself is 30% less. And then their hospitalizations are decreased by 3 to 4 days and such things. So it is amazing how, you know, your old drugs are being reused for this sort of stuff. So aspirin is one drug that we would like to continue even after the person recovers from COVID. And if the D-dimers are high, and like I said, if there is an indication for continuing anticoagulation according to the previous guidelines, which is not really COVID guidelines, but a person is hospitalized, he has been sick, he has been immobile, there are scores which you can use, and in which case you want to use anticoagulants, you can use 10 milligrams of rivaroxaban or such similar dosing for around 15 days to 45 days. There are circumstances in which we would like to combine an antiplatelet with an anticoagulant. These are patients who have cardiac ailments, who are known cardiac patients, who have had fresh stents, or who have had cardiac problems during COVID itself. In which case, rivaroxaban is the preferred DOAC, and you can use it at 2.5 twice a day, in addition to one of the antiplatelets. So that is a especially with aspirin, because that is something that has been tried out in long-term studies. So I think this is the way we do it. To just summarize, in the hospital, you use a moderate dose enoxaparin or the higher dose enoxaparin. At discharge, if the D-dimer is not very high, you just use an antiplatelet for 1 to 3 months. If the D-dimers are high, which most people would have, then you would use, you would remove the antiplatelet and use an anticoagulant only. And in circumstances where you would like to use both, you would use low dose rivaroxaban along with an antiplatelet.
Thank you, sir. Thank you. Sir, the next question is with Dr. Uday Jadhav, sir. Undetected clots often lead to strokes or infarcts in those who have emerged from the hospital. So what are the preventive regimes you would recommend, and for how long?
Okay, so if you look at the data carefully, the post-COVID delayed strokes are not as many. I mean, stroke can be acute presentation of COVID, and there have been reported cases, as in most of the other circulatory territories, of cerebrovascular events in the early COVID phase. Late COVID phase, let's say 3 months, 6 months after COVID, getting strokes has not been necessarily completely well established as a part of COVID-related thrombosis, cerebrovascular thrombosis. And therefore, there isn't a data to say that you use an antiplatelet agent over a long period of time in a patient of COVID who otherwise does not need aspirin to continue aspirin for, let's say, 6 months or 1 year for the sake of preventing a cerebrovascular stroke. But if there is a pre-existent, so two things, if there is a pre-existent cerebrovascular territory ischemia for whatever reasons, they need it, one. Two, if they have another vascular territory indication, like as Dr. Ramchandran was explaining, a coronary artery disease, then naturally you will benefit from preventing strokes or TIA by using antiplatelet. So that's my carry home.
Thank you, sir. Sir, the next question is with Dr. Ramchandra, sir. I guess this is last question also. How early can we start beta blockers?
So I think we don't want to start beta blockers in everyone with COVID unless there is an indication for it. So anyway, if the person has an indication for beta blockers, like he is hypertensive or and he's been on that drug previously, or is a heart failure patient, or he has some other electrical issue, you know, he had atrial fibrillation during COVID, which is something that's quite common in intensive care units. People have atrial fibrillation, and you might use beta blockers to control their heart rate, which is a very important usage of this drug. Then, of course, you would continue. But otherwise, I think the most common reason why we use beta blockers is for those patients who complain of palpitations during the recovery phase from COVID. And this is a huge segment. And like I said, we really don't know why they have palpitations. In our own experience, we have at least done for all patients that come to palpitations and at least sinus tachycardia, we've done cardiac MRIs in them. And very few of them actually have inflammation. So this is something like the Jaydeva thing that they presented, unlike the German studies. In fact, the German studies said troponins are also elevated even after months, but this is not what we find in India. So, but in this case, if the person has palpitations or sinus tachycardia, some people would use ivabradine for sinus tachycardia, some people would use beta blockers. I would use beta blockers because somehow the patient's symptom relief definitely seems to be better. And for all the other reasons that we talked about, its antiarrhythmic effects and, if there's any chance of QT prolongation with something going wrong in these people, of course. So I think beta blockers are the drugs that are used there. And here you would like to use a selective beta blocker like we talked about.
Thank you, sir. So, sir, with this, we have reached the end of this session. So, on behalf of Mankind Pharma, I would really like to thank you all, Dr. Uday Jadhav, sir, and Dr. Ramachandra, sir, for giving the wonderful presentations on cardiac care in COVID. And definitely, I'm sure all of the doctors who have joined us here, definitely they must had, I mean, various questions about this cardiac care in COVID, and they must have got their answers also. And we have got plenty of questions, but definitely, I mean, there were a few questions we could not take all the questions, so only the selected questions we could take. So I really apologize for that. But sir, definitely it's a wonderful session. So thank you, sir. Thank you, everyone, and thank you everyone for joining us here. Thank you, sir.
Sure. Thank you, Doctor. Thank you, Dr. Ramchandran. Thank you very much. My pleasure.